Typically, surgical orthodontics are cases that have larger skeletal discrepancies. And how do we determine whether or not you have larger skeletal discrepancies? Typically from our orthodontic records, there's a few x-rays that we take, and as part of orthodontic diagnosis and treatment plan, you're always looking at these x-rays to determine jaw-to-jaw relationships, okay, in 3 planes of space. How do jaws relate? How does the mandible relate to the maxilla? How does the maxilla relate to the rest of the skull? And there's the maxilla and the mandible that relate to each other hold the teeth. And it only makes sense that the better that the upper and lower jaws relate to each other, the easier it is to straighten teeth within that framework. If in fact we have a discrepancy with the framework or skeletal relations, sometimes it can be impossible to get teeth to line up. You might be able to straighten them in the upper jaw, maxilla, or the lower jaw, the mandible, but it may be very difficult to get the top and bottom teeth to relate together until you correct the framework. So what determines whether or not a patient needs skeletal change or surgery would be, it would depend on where their jaws were and how they relate to each other. And again, we determine that from x-rays. We do dental and skeletal analysis. A lot of times we're comparing a patient's skeletal and dental relations to norms, and we try to treat towards norms. They're typically nicer looking relations, and basically that's how we look to determine whether or not the surgery might be indicated. But it's the rarer. Most patients do not require jaw surgery in orthodontics. And again, one of the reasons we promote early treatment is because we can do a lot at younger ages to manage skeletal relations with growth and development versus waiting till a patient is older when growth and development is complete. And we're unable to make changes that way, and now we have to resort to a surgical approach to jaw correction.